So when we think about newer data sets that have come by, I think the most recent data set that really changed practice, at least in the United States, for certain patients, is the data from the phase 3 registrational EMERALD trial. So we know endocrine therapies work, but then they stop working. And one of the reasons that we wanted to develop better endocrine agents is to further improve the efficacy post-CDK4/6 inhibitors, because ESR1 mutations don't benefit with aromatase inhibitors. They're formed under the selective pressure of aromatase inhibitors. And certain ESR1 mutations don't benefit with Fulvestrant, such as Y537S. And Fulvestrant is also limited by its lack of oral bioavailability, and its efficacy is dose-dependent. So really encouraged by all the preclinical and the phase 1 trial data for novel endocrine agents such as oral SERDs, we are very excited now to have phase 3 randomized trial data that led to the approval of the very first oral SERD, Elacestrant. And the benefit was more pronounced in the ESR1 mutant patient population, which is where the label for approval is. So that's one data set. We have Alpelisib and Fulvestrant we use for patients whose tumors harbor PIK3CA mutations. We utilize them in the post-CDK4/6 setting based on the BYLieve data that gave us that confidence, and the approval was based on the SOLAR-1 study, which was predominantly CDK4/6 naive patients. But now we also have data, the new data that was presented at the San Antonio Breast Cancer Conference in December, where we saw results for capivasertib plus Fulvestrant, an AKT inhibitor, again a median PFS of 7.3 months in all comers and in the AKT pathway altered patient population. So we're awaiting to see if we are going to be utilizing this drug regardless of the alteration, or maybe more so in the altered patient population. And this might impact the way we think about our tumors and want to triage therapies for a given patient based on this information that we get.